Good afternoon, everyone, and thank you for coming. Otherwise, I'd be very lonesome without you. Notice that the Friday that starts in July, we are not having grand rounds because they're revamping the AV system in our conference center. So you'll be able to hear better, see better, learn more, be so smart. But otherwise, we'll continue through July, and then we go dark in August because people are often away from the area, and then resume in September. So you'll see at the handout where you signed in, there's a handout of what's the topic. The one coming up in July 18th is about back pain and ankylosing spondylitis by a speaker from Cedars. Well, today I'm going to talk about palliative and end-of-life care in pulmonary patients. This is a topic that we've talked about before. We do it all the time in pulmonary medicine in our patients who are suffering their dyspnea. And I wanted to highlight the palliative care program that we have at Hoag and how it's advanced since its inception in the late 1990s. My educational objective is to do an overview that you've heard perhaps before on palliative care, to learn more specifically about the treatment of symptom of dyspnea that does not get treated as well as it could, to understand the use of advanced care planning in helping your patients decide what their future might be. And if we get that far, because I have a lot of slides, unfortunately, is to recognize the impact of the compassion we give to patients causing us to have problems in struggling emotionally, having compassion fatigue. Of course, I have no personal conflict of interest for this presentation, but I thought I'd start out with a professional quiz. And some of you may have seen this before. And so we have a question for you. How do you put a giraffe into a refrigerator? Anybody have a... This is to see how sharp you really are in this Friday afternoon. Yes? Well, we'll go to the guru, and he says, you open the refrigerator, you put in the giraffe, and you close the door. All right, second question. It tests whether you tend to do simple things in an overly complicated way. Second question. How do you put an elephant into a refrigerator? Well, be brave. The answer, you open the refrigerator, take out the giraffe, put in the elephant, and then close the door. This tests your ability to think through your repercussions of your actions. Next question. The Lion King is hosting an animal conference. All the animals attend except one. Which animal does not attend? The elephant. It's in the refrigerator. All right. Last question. This tests your memory, of course. There's a river you must cross, but it is inhabited by crocodiles. How do you manage it? Answer, you swim across. All the crocodiles are attending the meeting. Enough frivolity. This tests whether you learn quickly from your mistakes. We've heard the phrase so many times, it's not the number of breaths you take in life that matters, it's the moments that take your breath away. And there are many places in this world that we have visited and so are amazed at the beauty that nature has provided here at Niagara Falls. And other beautiful places throughout our country in the fall, in the spring, in the summertime. The beautiful mountains for those who like to climb them. And this could go on and on. However, in lung disease patients, the moments that take their breath away are, oh my God, do I have to climb those stairs? And not just climbing up, but climbing down can be problematic as well. So we'll do an overview of palliative care. What does that mean? And I think it's become a specialty now with board certification, but in fact, it's something we have been doing all the time, every day, in the practice of medicine. It means patient and family-centered care, of course, that optimizes the quality of life by anticipating, preventing, and treating suffering. That's the key issue. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs. and to facilitate patient autonomy, access to information, and choice about what they want to do, even though the family may disagree. The definition by the World Health Organization several years ago was that we affirm life and regards dying as a normal process. It neither hastens nor postpones death. It provides relief from pain and dyspnea. It integrates the psychological and spiritual aspects of care. It focuses on quality of life, and importantly, provides a team approach, because no one can do it alone, to address the needs of patients, their families, and of course, those who are caring for the patient as well. Let me a little history going back to how palliative care got started here at Hoag. It was in 1999. And Dick Doring at the time contacted me as chair of the ethics committee and said, Paul, do we practice feudal care here? I says, yes, every day. In some fashion or form, we're keeping patients alive on the ventilator. You know they're never going to get them off. It just came a power of life. And so he suggested that we survey the people who are involved. So we surveyed families who had lost their loved ones in the preceding 6 months, our nursing staff, our respiratory therapy staff, our chaplains, our physicians, and others as well, and realized we had a lot of work to do. There were opportunities for improvement, is the fancy word that's used. And we started out with one FTE. Sharon Lucas was her name. It still is her name. She's a social worker who had run AIDS hospice units in Laguna Beach and came with that expertise and got many people involved. We asked the question, who wants to be involved in this project to improve end-of-life care at Hoag? And we got floods of people coming and wanted to be involved because they've been stung by it, by the poor quality of care that they got from this patient or this doctor or this nurse, to the point that we got a national award, the American Heart Association Circle of Life Award on Innovation and Excellence in Palliative Care, for building an entire hospital-wise palliative care program with one FTE. Many other hospitals came to ask us, how did you do it? And in fact, one of them in Santa Barbara Hospital had hired 5 people, nurse practitioner, physician, chaplain, I forget how all the rest were. They'd never seen their first patient. And pretty soon they'd have enough to do. And many hospitals did that in reverse. We started from the very beginning of one person. And then she left the area to go on pursue other activities, and another social worker came on board, Cheryl Stephan. And then we branched out when it was realized how much work we need to do. As now we have a team of 2 physicians, 1 clinical nurse specialist, 3 social workers, a chaplain, and a staff in the office providing inpatient and now outpatient care for palliative care as well. And our umbrella extends over other areas of focus. For example, you may or may not know that we have a perinatal loss team. There are perhaps about 50 or more perinatal losses of babies who die in utero in a year here at Hoag. We have 5,000 live births, and a small percentage of this may end up in demise. And how to help the family cope with this. The things you should say, things you should not say. The things you should not say, oh, you're young, you can have another baby, like that pregnancy never existed. And we had a presentation here a couple of Fridays ago by Dr. Marlon Mills, who's now a full-time perinatologist at Hoag, showing on how palliative care at the end of life that we do in palliative care is very similar to palliative care at the beginning of life when they've lost a baby. No One Dies Alone is a program developed in Oregon, I think, by a nurse who realized people die in the hospital and there's no family there. We got to do something about this. Her comments were that we weren't born alone, nor should we die alone. And so these are volunteers we have at Hoag, physicians, anybody in the hospital staff, some volunteers from the volunteer organization here at the hospital as well, that when the nurse or the social worker says, this elderly patient is dying, there is no family, someone please come and just stay with them. If you're a nurse, you don't do nursing. If you're a social worker, you're just there, hold the patient's hand, and be supportive. And that's been very successful. Oops. And lastly, just to emphasize we have for many years, bereavement services, focus groups, support groups for patients, for families who lost a loved one here at Hoag. Routinely, a letter goes out from the pastoral care office telling them how sorry we are that they lost their loved one until One went to a patient that was still alive. Oops, missed on that one, but that didn't kill the program. So this is a movie that many of us have seen, Field of Dreams, and I think this applies to what we're talking about, because I simply would say to visiting hospitals, build it, they will come. That was our experience of how we were able to advance this program significantly. So what do I mean by palliative care? This is a graph I think tells it the best. Let's say the diagnosis is one of COPD, and they start here at the diagnosis, and we try to do the best we can, get them to stop smoking, beginning bronchodilators, and treating them to try to slow the disease process. Generally, we can't cure them, and try to make them feel better. From the very beginning, when the patient is seen by the physician and they're short of breath and they're wheezing, the doctor prescribes an albuterol inhaler, and that's palliation. The symptom was dyspnea. The medicine helped to reduce it, and that we performed palliative medicine from the very beginning. And as the disease progresses from diagnosis until death, the therapies to modify the disease become less and less and less. And so therapies to relieve suffering and improve quality of life become the primary reason that we're caring for the patient at that time. And then comes a time in which life is going to be ending sometime in the next year. Life closure. I had an uncle, died of multiple myeloma, planned his own funeral as to what hymns would be the pallbearers, and how he would be dressed. He was what they call a farm agent in Pennsylvania, working for Penn State University, helping local farmers get their products out without the bugs getting them and what have you. And so his normal garb every day was boots, overalls, and a cap. And he decided that's how he's going to be dressed in his casket as well. Every other memorial service I've been to, person's dressed like they're going out to a party. I mean, they're all formal, waiting for their interview for somebody to help them, and his was so natural. When people came in to observe the memorial service, they said, yep, that's Tom. That's what he did in life, and that's what he did in death. And then we need to focus on the last hours of life. We make estimates about when people will die, but we don't know the correct answer each time. But how do we prepare the family? What do those gasping episodes mean? What is that death rattle? Hospitals are places that people die in, more commonly in nursing homes, rarely in their own homes now these days. And then finally, as I said, we provide bereavement support as well in many fashions. So you can actually begin to think that palliative care begins with smoking. If we get the teenager to stop smoking, or any age to stop smoking, you're likely to improve the quality of their life and their lung function. So we say that palliative care is really quite all-encompassing, and not just for the dying patient, although that's where we tend to focus our efforts. So it can occur to any diagnosis as causing symptoms, pain, shortness of breath, the list is long. Any age, even children, any time of the illness. It complements what the physician is doing to modify the disease, may become ultimately the total focus of care. If you've done everything I possibly could do for you with your lung disease and all you're left with severe dyspnea, I need to focus on that dyspnea as a primary reason for being involved with your care at all. There's multiple domains. You've seen this in the previous slide: physical, psychological, social, and spiritual needs. That's why you need a team. You need a chaplain to deal with the spiritual needs, for example. A social worker to deal with emotions. It is not just end-of-life care. Many of our physicians say, when a nurse suggests, maybe you got to call a palliative care team. My patient's not dying. No, we know that. But you think they might die within the next year? If the answer to that is yes, palliative care is a place to go. So what we did here was change it to a different word, supportive care. That sounds less death-rattling itself. And created what's called the Hoag CARES program, C-A-R-E-S, and you can see what those letters stand for. This was piloted in the GNP patients here over a period of a month or 6 weeks, and got a lot of positive feedback from patients saying, I'm glad someone came in and talked to me. I want to learn more about advanced directives. Just your being here and help me out and hold my hand, that's very helpful. And so this is what we call the program now, the CARES program. And this is our team. On the far left is Evelyn Fuller, who's the staff person, and Janet Batt in the scrubs, is our clinical nurse specialist. She's been a clinical nurse specialist in palliative care for 25 years in London, and we were able to capture her here and bring all the skills that she did there applied to our patients as well. Mona El Kurd is a social worker. She's working primarily on the outpatient aspect of palliative care. Vince Nguyen, who's our board certified family doc and board certified in palliative care. Kristen Fazzolaro, next to him, is a social worker, been very involved with patients' care in the ICU for years. Next is Dr. Kathy Ito, who was ward trained in UCI and is now on the Hoag staff, adding to those resources. And finally, Marie Toshinari, who's another social worker working at Hoag. Exclusively, that's all they do, is palliative care. I asked Vince to give me some slides if he could, and I got them this morning, so I'm going to review them with you. Just looking at the comparison. When we started this in 1999, that first year we saw 50 patients the entire year. Now you can see on the left, the total count, the referrals on the right are 667, last year 914, and we headed for over 1,000. A 20-time increase in the requests for palliative care of all kinds of issues. Not necessarily symptom management, not necessarily medications, maybe just anxiety, maybe just pain, maybe just spiritual stress. And we're connected with UC San Francisco that created a palliative care quality network where we can pair our work with 20 other California hospitals to get opportunities for improvement and how we take care of patients who are suffering. The average length of stay, just is the stuff that makes the leadership happier. This is compared to the UCSF program. The average length of stay prior to consult was 5.2 days in our program compared to 6.1 in the other hospitals. And the average length of stay from the consult until the discharge and disposition of the patient was dropped by 4.3 days compared to 5.4 in the other hospitals. And looking at the many symptoms that affect the patient near the end of life, the one that stands out is being comfortable and without pain, and we'll add to that, and being without dyspnea. Many symptoms going from the first visit of the team to the follow-up visit of the team shows improvement in nausea and vomiting, and pain and dyspnea and anxiety, depending upon the needs of that patient. So we're making success. So what do we mean by palliative care? We go back to the dictionary, and it tells us that patient comes from the Latin word patience, meaning to endure, to bear, to suffer. I found that very interesting. It's expected. A patient is suffering for some reason, and we need to address that. Palliate, meaning the word pallium, means to cloak, to alleviate, to ease, not necessarily to cure. So the palliative care approach is that this is integral to what we do every day, as I said before, about the new diagnosis of COPD or asthma. And every person that comes to a physician has the right to expect relief from their suffering, regardless of what the cause is. And they have a right to expect their physician to be concerned about their quality of life. Some of us do that well. As someone said, compassion was not handed out with a medical school diploma. It depends upon the personality of patients and physicians. One of our oncologist was approached by one of the nurses on our larger team saying, you need to do a better job. And he said, I don't like doing that job. I like what I do to care of the patients, but the end-of-life care is something I feel very uncomfortable about. In which case she said, call a palliative care team. Maybe they can come in and help out and be an adjunct to what you're doing. So who are candidates for palliative care? Anybody with distressing symptoms, fatigue, pain, dyspnea, anxiety, struggling with decision-making, for example. What's the next step? There's conflicting goals of care between what the patient wants and what the family wants and what the caregivers want. Or simply it's advancing illness. You know it's not going to go away. Stage 4 lung cancer, breast cancer, COPD, CHF, dementia, Lou Gehrig's disease, and simply the fact that we've lost our response to curative therapies. You need to change the focus on the goals of care. Joel Manchester, when he was alive and functioning, every time his patient would be going to cardiac surgery, he would say, have you signed out a living will? He said, why, am I going to die? No, it's highly unlikely you would die in cardiac surgery in this hospital. But Joel said, I'm not going to surgery, and I filled out a living will already, so sort of get with it. He's not just something who is going to be dying in the next year. Well, when you go to Medicare, they will qualify for hospice if they have disabling dyspnea at rest, a FEV1 less than 30% predicted. We have lots of patients like that, and they're not at hospice. They're still functioning at the best that they can do. Progression of disease, increased trips to the ER, hospitalizations is something we battle with right now. Or hypoxemia less than 55, saturation less than 88. All of those are something that our COPD patients have on almost a universal basis. And that doesn't mean we move them into hospice just because the Medicare said they will be able to pay for it. So 90% of us die in some kind of life-threatening illness. The other 10% maybe run over on the freeway or get shot or something. So there's a predictable steady decline. There's a lot of data that can help the oncologist make a judgment as to what's a 5-year survival, 3-year survival, 2-year survival of a patient of theirs. That's not the case with diseases that progressively get worse but have exacerbations in between, CHF, emphysema, Alzheimer's. For example, in cancer patients, there's a steady decline over time and ultimately the death appears. And so anywhere along that line, the physician would say, well, your time is limited. What about the patient with COPD? Well, they decline over time of their survival, but in between, they get an exacerbation of their COPD and have to be hospitalized, and their health status dramatically drops, but they come back. Never up to the same level they were before, but occurs again and again and again and again. Oh, this ended up being the last one. So if you ask the patient here, do you think you're dying? Well, no, I'm pretty sick. And I was in the hospital last month and my doctor bailed me out. I'm now doing as good as I could expect, I hope. Or we ask the physician the same thing. Is your patient dying? And you say no. But in fact, it could occur anywhere along the line. And there are messages along the line that we need to try to protect. I think of a patient I had many years ago who had metastatic breast cancer, has COPD, and she signed the ventilator paper. We discussed this in the office with her husband, that she didn't want to be on a ventilator. A few months went by, she crashed and burned, ended up in the ER, intubated, and up in the ICU when they found out she was even there. And I talked to the husband. You were there when she said she didn't want life-sustaining treatment, she didn't want a ventilator, she didn't want intravenous medications. He said, well, this is not life-threatening. She's going to be okay like she was before. It turned out later I found out that he was so riddled with guilt that if only I'd brought her in the day before, she'd be okay. It's my fault that my wife died. He said, now we have to deal with that grieving. Well, it's interesting. From a book on a guide to immigrants, Life in the United States, Americans do not like to talk directly about death. In America, people don't die, they pass. Or they pass away, or they expire, or they kick the bucket. Dead people are called the departed, or the loved ones. They're laid to rest rather than buried. People about to die are terminally ill, of course. Perhaps Americans have trouble talking about death because it is so remote. People no longer die at home, but in nursing homes or hospitals insulated from disease by medical science and from the horrors of war by two great oceans, Americans have made death what sex once was, the subject only alluded to. Got to be more open about that, folks. So what kind of symptoms do advanced lung disease patients, whether have COPD or pulmonary fibrosis, for example, dyspnea is our major focus. But a lot of them have pain, anxiety, depression, insomnia, nausea, vomiting, constipation, psychosocial issues. Delirium, many of them are very aged, in their 80s. Oh, there's probably some 80-year-olds here right now, and I don't mean that that's over the hill. How about depression? It's been estimated in several studies that much as 16 to 74% have depressive symptoms and not related to age, pack years of smoking, or lung function. It does associate with increased exacerbations, average length of stay, symptoms, lower survival, social functioning, and antidepressants will reduce depression and anxiety and symptoms, as does pulmonary rehab. We'll talk about that in a minute. There's a study done in Japan of nearly 400 patients with COPD, in which they found by those scales a prevalence of depression of about 45%. Depression untreated was associated with mortality, longer stay, persistent smoking at 6 months, and worse symptoms. And here's the graph. Survival in those who were treated, who had no depression, where'd my arrow go? Survivor was lower and who had depression. Re-exacerbations and return to the hospital was higher in patients who were depressed compared to those who were not. So many patients suffer at the end of life, a loss of control. They suffer pain, nausea, many symptoms, experience what Cicely Saunders, the founder of modern-day hospice, has called total pain. Physical pain, emotional, social, spiritual pain. They feel insecure in the healthcare system. I saw my brother die like this last month. I don't want to go that way. Or fear their caregivers are a burden and they don't want to be of concern to them. So the control of distressing symptoms is central to the practice of palliative medicine. It is a foundation of whole patient care, in that it's not possible to deal with psychological issues if the patient hurts. About 5 years ago, I fell and fractured my humerus, and I learned pain rules. When you hurt, you can't think of anything else, and it's amazing how much that can impair you. So there are many physical symptoms. We only want to talk about one of them, and that's the one that's paramountly important in our patients with COPD. So dyspnea in lung cancer is very common. 90% of non-small cell lung cancer suffer dyspnea near death. More in men, more in older patients, higher when the pain and anxiety are high, lower quality of life scores. This lady who had metastatic breast cancer said, "I just can't get enough air into my lungs. Every breath I take is such an effort, it's as if I'm wearing a lead jacket. I'm so frightened that the next breath will be my last. My family can't bear to see me like this. They don't know what to say or do. I can't hold my new granddaughter. I'm so weak. It's not fair. You've got to do something." And you can. And the things that we can do to help lessen, if not alleviate, this woman's concern. And then those with terminal dyspnea, almost everybody approaches the pearly gates, will have dyspnea near the end of life. What do we mean by dyspnea? You can spend your entire academic career trying to define it. Difficult breathing, labored, uncomfortable breathing, awareness of you're having trouble breathing, feeling breathlessness, suffocated, experiencing air hunger. It's very common symptoms. It's commonly observed. Change social respiration is part of the dying process that education of family needs to be made. The death rattle, agonal breathing, as I indicated before. As Rodney Dangerfield said, dyspnea gets no respect. If your patient fell and fractured their femur and came into the ER this afternoon, while their investigation is going on, their pain will be taken care of now. The ER docs give them their drug of choice, maybe morphine, and proceed to deal with the pain directly, the symptom of pain, while the hip is going to be repaired. If you had a patient who had COPD and came in with exacerbation of their disease and they're very short of breath, they will get oxygen, bronchodilators, antibiotics, other medications to treat their shortness of breath. Do we treat the dyspnea itself? No. Well, because, you have COPD, of course you're going to be short of breath. And we allow it to happen when, in fact, it could be addressed directly, as I hope you agree. So how can we assess dyspnea? I think the one that's most meaningful is a patient self-report. If they hurt, they hurt. You can't talk them out of it. It's part of what they do. We don't go through all this evaluation at times. It helps to know their FEV1 or their pulse ox or their blood gases or occasionally other observations as well. The American Thoracic Society came out with this scale a number of years ago, from none to very severe, and a description of what each category might be. Some physicians will use a visual analog scale. We like to use the Borg scale, which is used for pain primarily, but we use it for dyspnea as well. So we're exercising the patient in the pulmonary rehab program. We ask them, how short of breath are you on a scale from 0 to 10? If they say, I'm a 3, good, we'll keep going. If they say, I'm a 7 or 8, oh, we'll hold back. Let's take a rest. Maybe we'll come back to this again later in the session. It's an interesting phenomenon. In this study done in Japan of 183 COPD patients over 5 years, the cumulative 5-year survival was pretty good, at 73%, I thought. And it tested the mortality using ATS severity of airways obstruction versus level of dyspnea. And when you looked at the FEV1 in COPD patients, as time went on, the percent of survival was the lowest in those who had the highest amount of shortness, the greatest fall in their forced expiratory volume in 1 second. If they just looked at dyspnea itself, the patient lived an average of 25 months. It was when the death would come and knock on the door based on just that symptom. Because regardless, as I said, if you hurt, you hurt. We have to believe that from the patients, and shortness of breath is the same way. And this is a famous picture drawn by Netter many years ago, showing the classic pink puffer, skin and bone, using more calories to breathe than he eats, trying to do his pursed lip breathing, leans forward on his armrest because he can anchor his shoulders and get a bigger breath. His pants are open because it otherwise would impair his diaphragm from moving. He's doing the best to keep alive. If his shortness of breath is 8 out of 10, we would say, yes, we expect so. So let me ask, in your practices, do you regularly, at least daily for inpatients or each outpatient visit, use an intensity rating scale to assess and record dyspnea in patients with advanced lung disease? Pulmonologists in the back raise their hand. How short of breath are you? We teach our respiratory therapists in managing the ventilator. You make the ventilator work and have it go really smoothly. Before they walk away from the bed, if the patient is conscious, you say, are you feeling better? Do you feel less shortness of breath with the last change I made? So I put in this quote from Alphonse Karr, the French journalist and novelist, wrote, plus ça change, plus c'est la même chose, or the more things change, the more they remain the same. We need to move what direction we're going in. So the treatment is very involved. With treatment of dyspnea, I'd like to emphasize the importance of pulmonary rehab program we have here at Hoag for the outpatient, and we're having a little inroad now that we created a respiratory therapist navigator to go see COPD patients in the hospital when they're admitted with an exacerbation and help to assist in their care. And the physiologists give us this scale to say what causes shortness of breath, multiple potential causes, our own depression, fear, or anxiety, or impediment to breathing, like airways obstruction, or a high ventilatory drive. The bottom line is you're short of breath. Or as Marilyn said, I never wear bra because I believe in giving free play to my respiratory center. So we think it's very important to educate the family and the patient about their own care. In patients with COPD, for example, you have to pay attention to what the weather's like outside, but more importantly, the indoor environment. You come in to see your patient in the floors, and there are 4 people in the room or 5 relatives, and tell them to clear it out a little bit because it looks like the patient needs air that the others are stealing from him. Make sure the temperature is down, air conditioner, reduce humidity, fan, open window, cool compress to the face actually does treat dyspnea, and begin to talk about family advanced care planning and maybe introduction into palliative and maybe perhaps hospice care. The rehab program has been here since the 1970s, created by John Rumsfeld, is a team approach of respiratory therapists, often physical therapists, and social worker that conducts this program in the Hoag Tech buildings up the street. But now we've added an inpatient respiratory therapist. We call her a navigator for COPD patients and other lung diseases, interstitial fibrosis, for example. Our rehab program is a combination of both education and exercise. It classically meets twice a week for 8 weeks. Breathing retraining, advanced care planning, and results are decreased admissions, we hope. Patient satisfaction is high. They improve it in their symptoms. They learn. The thing they like the best of all is learning pursed lip breathing to decrease their sensation of dyspnea that they didn't consider themselves up to that point. The American Thoracic Society came out with guidelines on treating acute crisis dyspnea, as they call it, and came up with this for families, for caregivers, COMFORT, C-O-M-F-O-R-T. You can see what they stand for, as how to deal with a dyspnea crisis while you're getting support for more long-lasting care of the patient. What we need to do is more advanced care planning. We don't do that very often as a society. We deny death and we're going to live forever. The patients may not know what that is, the living will. That's pretty uncommon these days, I think, though. Or they consider advanced directive as giving up hope. Well, here's the story I told about Joel Manchester and how he has had a living will, and in fact, unto his death, as many of you may remember. As he was dying, he fought for every single day he could be alive. And his doctor said, Joel, give up. You've lost your hearing. We can't conquer this melanoma that you got. He said, every day I can add that to my life, the happier I'll be. And at his memorial service, at his funeral on the golf course, he had his son read a letter to all of us. I don't know how the young man did it, in which he said, basically Joel said, thank you for coming, but frankly, I'd rather be with you than being the subject of your comments. So he fought it to the very end, and that's his dignity. Harry Truman, if you remember, as a president, he had a sign on his desk, the buck stops here. My understanding is that he fought his life-threatening illness the same way. He fought it to the very end, because that's how he lived his entire life. Our society gets a little misperception of survival. When we do CPR here at Hoag, we may resuscitate the patient maybe 2/3 of the time, but only 20% end up leaving the hospital, either because DNR was started or they simply just had progressive illness and died. There may be cultural and religious differences. Physicians, patients don't even like to bring up that advanced directive discussion. Maybe using technical language, or sometimes it's a crisis, and let's talk about it today. Does your father want to be resuscitated or not? Limitations are not very many people have completed an advanced directive. I have, as a part of the family trust. They asked you to do that. I had been putting it off, and finally the lawyer said, are you smart or what? How do you want to make the decisions for what you want to be done? Well, my kids know. No, write it down. My wife did, and I did. The problem is that the content is vague, non-specific. There's no planning. It says fill out a form. You fill out a form, you put it in your safe box, your safety box. No one will see it. It's useless. The surrogate's not aware. The doctor wasn't aware. Circumstances are difficult to predict as to how much vigorous care you want in the ICU or not. Patient wishes can change with an illness. Family may ignore the instructions, override the surrogate. Physicians tend to reinterpret it according to the patient's status as well. So this man said, just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, unplug me, okay? She said, okay. And she unplugged his life-sustaining treatment. So how can we improve what we do? Bring up the subject. In pulmonary medicine, I think it's common for our physicians to have a sit-down with the patient and the family and talk about what happens if. What happens if you've been on a ventilator and I got you off last month before. And what if that happens again? What do you want us to do? If you have to be on a ventilator to keep you alive, or do you want me to focus instead on your comfort, on control of your dyspnea? And let's make a decision about doing that. And then try to follow through and pass that on to the hospital. If the patient has ever been a patient here, you have a blood test, chest x-ray, they're in the system, and the patient can fill out his advance directive and submit it to the medical records office, and it'll be there forever. And it has to be reviewed periodically is the ideal way to go. But the problem is it's not a physician order. If someone was DNR here at Hoag and they got transferred to a nursing home and they collapsed and arrested on the way, paramedics must resuscitate them. And the nursing home must resuscitate the patient because that order you wrote doesn't carry to those two places until Oregon came up with physician orders for life-sustaining treatment, the POLST, which is a signed medical document. It is bright pink. There's some out on the table. I got some more here. That you and your physician, your patient and your physician, discuss how you should answer this. What about you want artificial nutrition or not? How vigorous do you want me to be? You want to be resuscitated or not, etc. And then you sign the bottom. The patient signs at the bottom. You as a physician sign on the bottom. And this is now an order that's good in almost every state of the country. Even though they don't know who you are, don't know if you even have a medical license. You're registered here, and it becomes the rule for that patient's care into the future. And so patients are instructed to hold on to this. This belongs to the patient, not the doctor's office or the hospital. You leave a copy with those resources, but you go to the next visit, you go to the next hospitalization, and the practice here is that when somebody shows up in the ER with one of these and are being admitted, then we copy it and we give the pink sheet back to the patients or the family for care. When this was looked at in 2008, Oregon and Washington were the leaders, and West Virginia, I think that is, if I remember my geography. I got this off their website now. There are only a handful, 6, 7 states that have not made it legal to accept the pulsed. So maybe we'll go to those states if you're concerned about whether they respect it or not. So the treatment of shortness of breath is involving medications. That's not our topic for today, except to bring up the issue of opioids. In a patient with severe COPD, do you mean to give morphine to the patient with advanced lung disease? Won't that slow down the patient's breathing, cause the CO2 to rise, maybe even kill the patient? No. I had an aha moment. A lady I had on the ventilator for a year here at Hoag, and would visit her at home. And this one of these visits, she said, Dr. Slecki, the medicine I like best that you gave me is that Hycodan syrup. And suddenly, bing, it has codeine in it, or codeine derivative. That's what's making her feel better, not the bronchodilators, the inhaled nebulized document, etc. So the question is this an ethical concern if we're giving morphine to a dyspneic patient? Well, you have to examine treatment dyspnea as an important obligation you must treat just like pain. There are many available therapies for the treatment of dyspnea. Focus on relieving symptoms and maximizing quality of life because presently many of our patients suffer poor quality end-of-life care compared to patients with cancer because it's less predictable as to whether that disease flare is going to end up in the patient's death or not. So treatment should not be withheld because of concerns for addiction or overdosing. You don't go to start stealing television simply because they're on morphine at home. It brings up the principle of double effect. Although the treatment may hasten death, the aim of increasing doses of opioids or sedatives is to relieve dyspnea after ventilator withdrawal, in a study done at UC San Francisco. And they said in the article, no evidence that the use of narcotics or benzodiazepines to treat discomfort after withdrawal of life support doesn't hasten death in critically ill patients. For every 1 milligram per hour increase in the medication use, the time of death was increased by only 13 minutes. Not significant. What is this ethical doctrine of double effect that applies to many things, including this situation? The act itself must be morally good or neutral. Yes, we're to treat the patient's shortness of breath. Only the good consequences of the act must be intended. Yes, relief from suffering. I'm not going to kill the patient. The good effect must not be produced by killing the patient, the evil effect. And realizing that you have a weighty reason for permitting the evil, risk of great suffering through a higher risk of death is not appropriate. Here's a study, 18 randomized controlled trials of drugs given either oral, parenteral, or nebulized. And in these patients listed there was no drop in O2 saturation, no rise in CO2 more than 40 in 11 studies. Strong effect on relieving dyspnea. Possible effect on exercise tolerance, nausea, vomiting, constipation. Nebulized opioids are not different from placebo. Sometimes that's hard for physicians to understand. We give nebulized medications all the time in COPD, and that's very appropriate. You get the drug to where the spasm is. Dyspnea is much more widespread than just the lung itself. So giving nebulized opioids sounds like it makes sense. It doesn't work. It's not any better than placebo. Here's a randomized control of only 6 patients with nebulized morphine, did not improve dyspnea during exercise or exercise performance. The AMA and their educating physicians on end-of-life care, the EPIC program, 10 years ago, maybe even longer, recommended morphine sulfate 5 milligrams Q4 RSPO. Shannon Batt, who I mentioned is our clinical nurse specialist, who is trained in London. She ran a breathlessness clinic, and she would pass out morphine sulfate a couple times a day to the patients, focusing on their dyspnea. You must assess the patient response, visual analog scale, increasing the dose if you need to. This is what they recommend in that particular publication for mild dyspnea, severe dyspnea. We won't get into the details, sometimes combining with anxiolytics if they're anxious, and palliative sedation at the very end of life where we can't relieve their suffering. We basically almost put them to sleep. There are many guidelines that have been published, American Thoracic Society, American College of Chest Physicians, and others, asking us to please use morphine or other opioids. Guidelines for treatment of dyspnea in mild, moderate, or severe opioids appear at the highest level. The ATS has a policy on needing what drugs to use, what doses to use, what route to use, and including a pediatric session as well. So it's in print, 2008. American College of Physicians, for internists, recommend that patients with serious illness at the end of life, clinicians should use effective therapies to manage dyspnea, which includes opioids and pains with unrelieved dyspnea, and oxygen, of course, for short-term hypoxemia. Strong recommendation. The ACCP came out with guidelines on the treatment of dyspnea itself, and they said that evidence supports the use of non-pharmacologic treatments, the use of beta agonists, anticholinergics, use of opioids in dyspneic patients with advanced lung disease, and they are safe. However, side effects like constipation may affect their quality of life. It does not support the use of nebulized opioids for dyspnea. As far as I know, we don't do that here at all, or only rarely. It does not support routinely giving anxiolytics to patients or antidepressant unless they have that psychological disorder. Or call the CARES team. Not sure what to do next, how to juggle these issues. Social work, it doesn't mean the whole team comes. If it's an issue of helping the family understand, perhaps the social worker would go, maybe the nurse specialist would go. Or if the patient is an outpatient, consider putting them into the pulmonary rehab program. So there's a lot of benefit from palliative care. Quality of life improves, better control of pain, higher patient and family satisfaction, shorter ICU, hospital length of stay, savings in ancillary services and pharmacy costs make sense because they spend less time in the hospital. But there are obstacles. Palliative care thought for only the dying patient, underutilization, late referral, limited to crisis intervention, limited community versus lack of advanced care planning, sometimes our own response, so-called compassion fatigue. We are compassionate people. This is why we've chosen this profession. Even as Cicely Saunders was quizzed, why did you go into medicine? Just because I like to help people. And that's why there's some who don't directly work with patients themselves, but still are in this field because we want to care for patients. And that compassion we provide for our patients is based on a therapeutic alliance between us and them, so-called brotherly love, but it's asymmetrical. We're hoping they will listen to our guidance. It involves transference, counter-transference, but we have a fiduciary responsibility for patient care. And empathy has a price. It's defined as a way of being. The helper, us, without judgment, enters the private world of the patient. It amazes to me. Patients we've never ever seen before, and suddenly they trust us because they know we're in their care. Same thing with our respiratory therapists, with our nurses as well. However, we may actually find an insight beyond that of the patient into the patient's own story, discerning what is the story behind the story. Are we willing to take on this burden? We have to watch how our emotions may impact on what we say or do. The respiratory therapist, the nurse is assigned to a patient that looks like their Aunt Martha, who died several years ago, and the nurse has been feeling guilty. Why didn't I go visit her? Why didn't I send her notes? I failed her, and almost tries to make an association. This lady looks like my Aunt Martha. Or, I never liked my Aunt Martha. She always picked on me. She always told my mother that I was misbehaving. So I don't want to go take care of this lady who looks like Aunt Martha. It's underneath how we feel as individuals. So what is it? Compassion fatigue. Burnout, all these fancy names. It leads to withdrawal from others, anger, hostility, feeling overwhelmed, constant sense of pressure, and the list is long as we take over this role of being a caregiver or avoiding the patient or the family. The nurse says, I don't want to have 722 again in assignment because it's been driving me nuts. This family is screaming all the time. Maybe it's time to change therapists. Give yourself a little rest, get somebody else. Warning symptoms, anger at the patient or family, feeling imposed upon, harassed by patient or family, belief that complaints of distress are manipulative, sense of failure or self-blame, guilt, feeling a personal obligation to save the patient. Some of our doctors function that way. or feeling victimized by the demands of practice. So I don't know how you deal with the stresses you have in life, but they're suggesting take time for yourself, for your team, develop a self-care plan, find someone to talk to. They say, sure, you take your problems home. I do. My wife is a nurse. She hasn't practiced nursing in many, many, many years. She's been having babies. Now she's a grandma. But we chat about that. Get enough sleep? You try. Less alcohol. That's important. That's a good guideline also. Exercise and eat healthfully. Develop interests outside of medicine, like at your synagogue or your church. Identify what's really important to you. Or in the Hoag Hospital here, we have a program called Tea Time for the Soul. If there have been a lot of deaths on a unit the nurses are struggling with, or the respiratory therapist, call Don Oliver down in the pastoral care office, and he'll come up during one of the nursing breaks in the break room and have goodies to just talk about how things are and what was your feeling about that patient you took care of last week that died. Maybe sometimes a note is written by the pastoral team to the family that they were talking about your loved one's care. So some of us really relish what we do every day. We wouldn't find such success in any other profession. The traits of these people who stay joyful despite the stress are a sense of humor, strong support from others like family, clear values, openness to patient's appreciation. Physicians don't like to get gifts. It makes you feel unease. I didn't do this because I wanted a gift from you, but maybe it's okay, and let the patient or the family provide that resource for you. Collegiality with your team, awareness of your own needs. So what is palliative care? We started with this slide. It means patient and family-centered care that optimizes the quality of life by anticipating, preventing, and treating suffering. Here's some resources, national guidelines on palliative care in cancer patients. Many years ago, Rumsfeld had a news briefing for the Department of Defense, and he talked about what's going on in Vietnam, and he said, as we know, there are known knowns. There are things we know, we also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns, the ones we don't know, we don't know. So, what we do know is that when you can't breathe, nothing else matters. So Churchill said, when you're going through hell, keep going. Thank you very much.